Hi, everyone, and welcome to the Clinics Review Articles podcast series. I'm Taylor Hayes, the managing editor for Facial Plastic Surgery Clinics here at Elsevier. Facial Plastic Surgery Clinics is a quarterly publication that provides clinical and scientific aspects of the latest cosmetic and reconstruction techniques and materials. Joining me today is consulting editor Dr. Anthony Scalfani to lead the discussion with the guest editor, Dr. Jessica Lighthall, of the August 2025 issue.
Well, hello and welcome. Anthony Scalfani, I'm the consulting editor for Facial Plastic Surgery Clinics, and I'm speaking today with Dr. Jessica Lighthall, the guest editor of the current issue of Facial Plastic Surgery Clinics on facial and neck trauma. Dr. Lighthall, would you like to introduce yourself?
I'm Jessica Lighthall. I'm the chief of facial plastic and reconstructive surgery and an associate professor in otolaryngology at Penn State Health. One of my specialties is facial trauma, and it's been wonderful being involved in this issue of face and neck trauma for facial plastic surgery clinics.
Definitely thank you for curating this issue of Facial Plastic Surgery Clinics. You have really put together a tremendous set of articles that cover bony and soft tissue facial and neck trauma in great detail. I strongly encourage our listeners to access the issue either online or in print. And for this podcast, I would like to discuss some important concepts for all healthcare providers involved in the care of head and neck trauma patients. It really has been a wonderful experience to read through the entire issue. And just want to pick out a few points that maybe you would like to comment on, Dr. Lighthall. Just to start off at the beginning, based on some of these articles, what words of advice could you give to the facial plastic surgeon who is just starting their career or really doesn't perform craniomaxillofacial surgery that often, particularly bony orbital trauma? Are there good cases to start with? Are there techniques that really should be mastered? How does it overlap with what we can traditionally consider cosmetic facial plastic surgery? And which cases are more challenging? And what are some red flags that might make it more worthwhile to bring in an oculoplastic colleague?
So coming out into practice as an early surgeon, it can be a little bit anxiety provoking. I think we get phenomenal training throughout most of our fellowships, and we're dually board certified. So we're very comfortable in the facial skeleton from both our head and neck training as well as our facial plastic and reconstructive surgery training. And a lot of the approaches to the orbit we already do as part of our aesthetic training, whether it's blepharoplasties, mid-face lifts. We're used to being more in the soft tissue around the orbit. But I think where a lot of young surgeons become uncomfortable is when they're doing more complex orbital trauma, mostly because it's around the eye and potential complications can be difficult to treat, and they can have significant quality of life and functional outcomes that may not be ideal for patients if they're not doing things correctly. I think one of the beautiful things about working in facial trauma, especially in our academic centers, is we have so many colleagues with a variety of expertise, whether it's our ophthalmology, oculoplastics colleagues, our general plastics colleagues, or oral maxillofacial surgeons, as well as more senior facial plastic surgeons to work with. I think if you take nothing else from this, it would be to reach out to your colleagues. You'll find that they're very happy to help. It's a friendly, collaborative environment. And I learned something even at my stage from involving some of my oculoplastics colleagues for more complex orbital trauma. I think the more simple cases to start off with would be some straightforward orbital floor fractures, particularly fractures that don't involve the transition point to the medial orbital wall. They don't have multiple walls involved. And when you're looking at the fractures, they have pretty good bony ledges circumferentially, particularly posteriorly. I think those are really ones where you can get your feet wet in orbital trauma, learn the anatomy really well when it's not completely distorted, and understand the orbital volumes and symmetries a lot better. The other advice I would give is to use some of the new adjuncts that we have. We are all comfortable in facial plastic and reconstructive surgery using endoscopes. This can be a nice adjunct to really evaluate the walls and the floor and make sure that the anatomy is where it wants to be and your reconstruction is where you want it to be, as well as intraoperative imaging. I think it's helpful. And even just kind of working through it on more of a mental level with virtual surgical planning, looking at orbital volumes, normal shape of the contralateral orbital floors and orbital walls, I think can be very helpful to understand basic anatomy, some differences in anatomy, and really how you optimize your outcomes. Red flags, I think, come from fractures that are more complex, involving that medial orbital wall or that transition point that really aren't noticed. If there's no posterior ledge, it can be challenging because there's not a lot to rest a plate on. And then more complex traumas, oftentimes these orbital fractures don't come in isolation. They come with complex rim fractures, midface fractures, frontal sinus roof fractures. And that's when it gets a bit more complicated, and you really have to be cautious about reconstructing a normal and symmetric orbital volume.
Thank you. I think those are really great points, and I think that depending on where you are in your practice lifespan, you're going to come across fractures more frequently or less frequently. And for the surgeon working in an academic center, we have ready access to our oculoplastics colleagues. For someone who's in private practice who may be doing an orbital fracture in a surgery center, it becomes a little more difficult. So, one of the things that we always stress is that patient needs to have an ophthalmologic evaluation preoperatively, right? So that's probably a great tool to start to discern which of those cases are appropriate to be done at which settings. And I think I echo your sentiments in saying that, my oculoplastic surgeon colleagues, and I think most oculoplastic surgeons are more than willing to collaborate and work together. And frankly, the more of these cases you do, the less mystifying the other side of the orbital wall becomes. You become a little more confident, a little more comfortable in doing these cases. And which sort of lends to the next topic of, well, we're right adjacent to that. I think most facial plastic surgeons feel very comfortable working on zygomatic fractures. And so what's new in the horizon? What are some key points in terms of managing zygomatic fractures that are covered in this issue?
Yeah, I think historically, when we're working on zygomatic fractures, we're really trying to reconstruct the width and the projection of the face. And we do this quite a bit with clinical evaluation. So you reduce a fracture and you kind of look at both sides and you say, how's my symmetry? But I think we're becoming a little bit more nuanced, a little bit more technical in how we assess this and we plan our reconstructions. I mentioned earlier intraoperative CT scanning. I think if you have this capability, and many institutions do now, you can immediately assess your 3D kind of reconstruction and confirm it's where it needs to be. Many surgeons are also using preoperative planning to create kind of idealized models and reducing the fractures virtually, coming up with models, using that as a guide for your reduction. You may be using that as a guide for bending your plates if you're not going to be using your intraoperative imaging. And then many of us are also very comfortable with endoscopy and navigation. And some of these virtually reduced models can be uploaded onto your navigation system and used to confirm you have pretty close to ideal reduction of your fractures so that you minimize the chance of having just small differences that can create a delayed asymmetry in the facial skeleton. And then remembering to, resuspend all soft tissues, because that is also a component of this. There's more of a focus on that and not just the bony reduction of the fractures.
That's a great point. I always find it interesting that we as facial plastic surgeons in approaching bony trauma in general will focus so tightly on the bone that for a field that is all about soft tissue suspension, we sometimes really don't talk as much as we ought to about soft tissue suspension, resuspension after mobilizing these bony segments. Those are all really fantastic points. I'm going to sort of jump around a little bit and kind of bring in one point that you mentioned about the orbit and about dealing with orbital issues. The role and the scenario of pediatric fractures comes up, and there are certainly some differences. And you've mentioned newer technology, and you've mentioned some other specifics already in general. But can you comment on how new technology impacts the management of pediatric fractures?
Yeah, that's a great point. I think a lot of these different fracture patterns, the more experience you have, the more comfortable you become with them. And you do need to learn the differences, but similar to orbital fracture, the more you do, the better your outcomes will be. And certainly if you're not very experienced in pediatric fractures, bring in someone who is. Children are not just little adults. They do have very big differences throughout their lifespan of alterations in ratios of the facial skeleton and more likely fracture patterns, and potentially some impact on growth centers when we're talking about mandible fractures or even maxilla fractures. You have a very complex dental picture with a mixed dentition in certain age groups. Once you get past, the 12, 13, 14, they tend to have a more of the adult dentition and occlusal patterns, and you can use some of those skills. But when you're thinking about children, it's not just where the fracture is, but it's where your incisions are. If you're going to put in hardware, what's going to be growing around that? Your plate's going to impact growth. And so all those things need to be taken into consideration. Again, I think that the newer techniques and advances that we have, whether it's using absorbable plates in appropriate locations for mid-face fractures or upper face fractures, or removing hardware, these all need to be taken into consideration. There are quite a few occlusal splints that can now be made to assist in fracture reduction and fixation. But going back to some of the old tried and true techniques of circummandibular wiring, et cetera, can be very helpful. We tend to be less aggressive with pediatric fractures when possible. They tend to heal up beautifully. We've all seen the children who've had 2 or 3 mandibular fractures, but dentition overall is not poor. The occlusion's not poor, and you observe them and they heal up quite remarkably. But you really want to minimize creating a secondary problem and intervene when necessary, particularly in the mandible and mid-face.
Fantastic. Thank you. And again, this issue, I just re-emphasize to listeners, covers the basics, but it also covers these really, really specific and sometimes problematic issues that you may not come up against every day. And also, it does suggest and discuss newer techniques and newer technologies that are coming online and perhaps newer ways of thinking about things. We won't have time to talk about it here, but particularly about soft tissue neck trauma. And the zones of the neck may not be as important a guideline as we had been trained to think. Let's get back to mandibles, because that's certainly something we see much more commonly. Mandible fractures can be quite challenging, in particular condylar fractures. There's been this persistent battle between the proponents and opponents of maxillomandibular fixation versus open condylar surgery. Can you comment a little bit about that and what we can expect from this issue?
The article that's specifically related to condylar fractures is really key because you have experts in both oral and maxillofacial surgery who lean more towards, in the literature, open approaches, with facial plastic and reconstructive surgeons and otolaryngologists who classically in the literature lean more towards less invasive maxillomandibular fixation, and working together in that collaborative form kind of identify which cases are really ideal to proceed with open reduction. I think, just as we've spoken with earlier in this podcast, the more familiarity you have, the better you do, the better you're able to treat patients and really identify patient groups that may be more appropriate for a closed approach with maxillomandibular fixation, and those who really would warrant open approach for improved outcomes. We know that for all approaches, it's very much experience driven. So certain complications, such as a concern for facial nerve weakness and injury, may be nerve-wracking for people when they're trying to think about doing an open approach. But really, the more you learn about these and you see some of these examples and the outcomes, really picking which patients would be appropriate where that risk may actually outweigh the benefits and vice versa. This article that we have on condylar fractures really touches on all of these and helps us try to frame our thought process in picking patients which is more appropriate for open versus closed.
One specific thing is, again, classically we've been trained, to be relatively aggressive with frontal sinus fractures in terms of concern about mucoceles and late complications. But the prevalence of endoscopic techniques, even within sinus surgery, I think has changed that paradigm. And you have an article that really does talk about that. Can you comment on that in terms of where things may be going in terms of management of frontal sinus fractures?
Absolutely. This I think, is a really key article talking about the change in the paradigm for frontal sinus fractures. As you mentioned, there were, really broad indications for obliteration and cranialization of the frontal sinus in the past. And now really with, I think I will say kind of the rise and popularity of endoscopic skull-based surgery and frontal sinus surgery and new equipment, new devices that we can use to access fractures, the shift is really towards sinus preservation when possible. Now, this doesn't mean that that's appropriate for all the cases. Certainly, we know that these are very high force injuries. They're often associated with other complex facial fractures, skull fractures, intracranial injuries, and bleeds that really may require intervention. And you can have quite severe frontal sinus fractures where really still obliteration, or I would say more towards cranialization, is appropriate. However, if there's not significant involvement in the frontal sinus outflow tract, a persistent CSF leak, or another indication really pushing you towards a cranialization or removing the sinus from the equation, then sinus preservation is an option. And that does not mean leave it and ignore it. That means you follow it. And that time frame is debated how far after you do. And if a CSF leak resolves, if there's not severe comminution and displacement, then really you can observe that sinus and preserve it and make sure in delayed CT scanning that it aerates again. And then you've preserved that sinus. If it doesn't aerate in a delayed fashion, then you really can involve either yourself if you have the skills necessary, or one of your colleagues if you're at an institution where this is available, to intervene on that frontal sinus outflow tract and try to preserve that frontal sinus. So I think that's really where the big paradigm shift is towards being less aggressive in the initial removal of the frontal sinus and leaning more towards observation and preservation when possible.
One thing that strikes me is that for that frontal sinus trauma article, I think we have in the U.S. have gotten used to viewing a dichotomy, so to speak, in terms of the results and the approach versus other countries, say Scandinavia, where patients are generally, they'll live within 50 miles of where they were born for, in a significant percentage compared to the U.S., where we don't have these long-term range follow-ups. And now what you're really talking about is we have the technology to follow until we have functional proof that that is an aerated functional sinus. And if it's not, then we have, again, the technology to intervene without losing that sinus. And I think that's really an interesting change in how we think about things. And I'm going to use that as a segue to come to your article, Dr. Lighthall, about technology and 3D printing and virtual surgical planning and custom-made implants and endoscopy. What would you like to leave the listener and the reader with in terms of that topic?
Yeah, thanks for those points and that question. I think with the advent of 3D printing and surgical planning, the world is your oyster. You're not limited to what you can learn, how you prepare for cases. I think you can take each facial trauma, you upload the images, and you can really look at it critically before you even intervene and say, how do these need to be reduced to restore a normal, symmetric facial function? What are the challenges going to be? Am I going to lose bone? Do I need to bring bone in? What types of approaches am I going to be from the classic top down, outside in? Can I be a little bit more patient specific in how I approach these? And then what can I do to improve the outcomes? What can I do to shorten the length of surgery? As you know, for some of these complex procedures, they are full day procedures and even then some and maybe multiple stages. So what can we do to minimize the risk of complications? What can we do to optimize the functional outcomes from occlusion, minimize trismus, get that orbital volume just perfect, particularly in complex fractures where you're dealing with multiple segments and sometimes kind of eggshell pieces of bone? I think if anything else, this has incredibly improved my patient outcomes and helps me understand the biomechanical process of facial fracture repair. There are so many different things that you can use now. I think one of the key things, if you take nothing else away, is these occlusal splints have really improved my practice. That can be made now off of just a fine cut CT scan. You don't need any special occlusal scans anymore. But also for education and training the next generation, of our surgeons. These are complex procedures to learn. So utilizing these techniques, you can get models for education, models for plate bending. You can get patient-specific implants where appropriate. I don't think that's appropriate for all cases just due to the expense, but when you can save significant amount of time and improve outcomes, I think they are highly valuable. And it's very exciting to see the rapid kind of progression of utilization of these advanced technologies to improve our patient outcomes.
Thank you, Dr. Lighthall. Thank you for this conversation. Thank you for putting together this issue. To our readers, I can assure you we have only just scratched the surface of the topics covered in this outstanding issue of Facial Plastic Surgery Clinics. Dr. Lighthall and her authors have produced an issue that really does cover the state of the art and gives insight into the care of facial trauma patients for now and for the future. And I hope you take a look at this fantastic issue of Facial Plastic Surgery Clinics. It will absolutely be time well spent.
Thanks so much for taking the time to speak with us today, and thank you to our listeners for joining us for this edition of the Clinics Review Articles podcast series. For an exclusive discount on the issue we discussed today, focusing on face and neck trauma, visit us.elsevierhealth.com/expert. Facial Plastic Surgery Clinics is available for individual print subscription with accompanying online access, as well as individual online-only access. And it is also available on Elsevier's electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 65 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter at Clinics Reviews and subscribe to the Clinics Review Articles podcast wherever you get your podcasts. Thanks for listening.